Thank you very much. I would like to thank the organizer for inviting me. I talk today about the update on the management of pulmonary embolism. So two things important for me when I see a patient with pulmonary embolism. Number one, it is a high mortality. If the patient is unstable, the mortality is very high, 32%. If the patient is stable, the mortality is only 3.4%. The second one, it is if we use intravenous thrombolytic therapy, the chance for stroke, acute bleeding in the brain is 3% or 2%. This data go along with the data in 1990 when we give the medication thrombolytic therapy to patients with acute myocardial infarction. The rate of stroke is 1%. So when we see a patient with pulmonary embolism, we have to stratify the patient in very high risk, intermediate risk, and low risk. The high risk we have here, it is if the blood pressure is below 90 millimeter mercury in more than 5 minutes, if the patient need to use pressors, or if the patient has no pulse, or if the patient has slow heart rate below 40. The second group of patient is a patient had no low blood pressure, but the patient had the right ventricular dysfunction, and also the patient had myocardial necrosis by enzyme. And the low risk of patient, they have good blood pressure, no right ventricular dysfunction, and no myocardial necrosis. Another important, very important factor when we treat the patient with pulmonary embolism, it is the right ventricle. So if the patient develops right ventricular dysfunction, or if the right ventricle becomes dilated, and the ratio between the right ventricle and left ventricle is more than 0.9, that means the patient is very high risk. When we see that, yes, we can use the treatment, but one of the problem, if the patient, let's say in the hospital, we don't have invasive treatment, and we say, yes, we want only to have intravenous treatment, so what's the result? Number one, we know that the mortality, the rate of intracranial bleeding is 1 to 2%, but the most important one is if we give intravenous thrombolytic therapy, TPA, if the patient has a large thrombus, at that time the patient has slow flow in that area, and the slow flow will not bring the medication to the site of the thrombus. It's the same like when we have a patient with right coronary artery occlusion due to inferior wall MI. The medication, the TPA we give intravenously will not be brought from the systemic system, from the blood, to the artery, to the thrombus, because there's no flow. This is why it's nice, it's good, it's understandable if we use intravenous thrombolytic therapy, but the problem we have, maybe it is not efficient and efficacious enough for the treatment. Now, so this is why in my hospital, we don't talk about questioning, we don't talk about denial, we don't talk about maybe. We go straight when we have a patient with pulmonary embolism. If the patient meets all the criteria of severe pulmonary embolism, we give the patient thrombolytic therapy, but we use with an EKOS catheter. And here is the indication: high risk, intermediate risk, and if the right ventricle is dilated and the systolic function decreases. And here it is, we use the equipment, and it's not difficult for us, for interventional cardiologists, to put the catheter inside the pulmonary vein. It's not difficult. The technique is very simple. Even the patients, the doctor we call invasive cardiologist can do it. Like we put a catheter to measure the pulmonary artery pressure, or we call the Swan-Ganz catheter. The reason why we have to use this special technique, because we have to use ultrasound to facilitate the movement of the blood, of the medication. The reason because plasminogen receptor site are embedded deeply into the thrombus during formation. And the speed of lysis depends on the ability of the thrombolytic therapy to reach or to access this plasminogen site. The tiny form fibrin strands prevent the drug to penetrate the thrombus, thus limiting access to plasminogen receptor site. And by that, the ultrasound energy causes fibrin strand to thin and loosen, exposing plasminogen receptor site to the medication. Also, the pressure wave, the ultrasound pressure waves force the drug deep into the clot and keep the medication there. As the result, we see that the drug acts faster, clearing the clot sooner, and with reduced bleeding complication. The patient had no hemolysis, no valve damage, and very low risk of embolization and bleeding. This is why we need to use better equipment to be sure the result is optimal and the complication rate much lower. When we talk about ultrasound energy, you remember that we use ultrasound energy to break the stone in the kidneys. And this is very important for the ultrasound energy to break the thrombus, so the TPA with a much lower dose can be used for this patient. Now, we can use different technique or different equipment. For example, the angiovac device. But this one needs a 24 French catheter, venous access, and we need venous bypass. And in the treatment of patient, if we do anything simple, cheap, and successful, this is the best for the patient. In conclusion, now we have to, this slide shows that this is the result we asked for. Here the patient come with an enlarged right ventricle and systolic dysfunction. Yes, maybe the patient is still stable, but remember in 3 months, the pulmonary hypertension becomes worse, and it's much more difficult for us to treat the patient. And we have to use much stronger medication for pulmonary hypertension, and not everywhere we have available this medication. This is why after many years treating patients with conservative treatment for pulmonary embolism, I witnessed many miserable patients with heart failure, right heart failure, pulmonary hypertension. Since we have the new equipment, since we have the new way of treatment, many patients became much better, improved, and came back to their normal lifestyle. In conclusion, number one, we remember we need to classify the patient, the high-risk patient, the intermediate risk patient, and we should remember to look at the size and the function of the right ventricle. Number two, it's not difficult to put the catheter in the pulmonary vein to give the treatment. And number three, this is the outcome we request. We wish all the best for the patient, but we're sure we have to deliver the result. Thank you very much. At the end, I should like to announce that at 12:30 p.m. today, in room 302 outside this door, we will have a special symposium. It is a SCAI and Heart Rhythm Society satellite symposium about the left atrium appendix closure, the one we just heard from the previous speaker. And the speaker will be Dr. Saigon Bar from Cedars-Sinai. It's a very well-known structural intervention cardiologist from the U.S., and with President Han Ya-Ling, a close friend of mine for many years. Thank you very much.